Welcome, everyone. My name is Samir Kakodkar. I'm a gastroenterologist and specialist in ulcerative colitis and Crohn's disease. Welcome to Against the Grain. Please do check out the rest of my podcasts, which can be found at the website samir3.podomatic.com. It can also be found on YouTube or Spotify by searching my first and last name. For those who are interested in contacting me regarding questions or for virtual appointments, my email is samir3@gmail.com. On Facebook, you can search Against the Grain to join the private group where there are ongoing discussions about these podcasts. First, we have Kim Beal. If you just briefly introduce yourself.
Okay. Well, thank you, Dr. Kakodkar, for inviting me to participate with you today. My name is Kim Bell. I'm a PharmD and a founder of a new nonprofit organization, Nutritional Therapy for IBD, that's dedicated to promoting awareness of dietary therapy and providing resources for clinicians and patients to aid in dietary incorporation into clinical practice. So, as such, we are closely following all dietary research, and our website has often been described as the most comprehensive source of information for nutrition and IBD. So, of course, we're very interested in the Dine study today as well, and we look forward to talking with you about it. I'd like to mention that we, as an organization, we also support awareness of ongoing dietary research to aid recruitment, and we welcome all researchers to include an enrollment link on our website. We have an NT for IBD exhibit that we provide at national GI conferences. And what we've done in the past year is include flyers for actively recruiting dietary studies. And we've done this so far for Produce, Melody, and Dine CD as well.
Great. Kim, sorry, I think I mispronounced your last name. It's Bell, right?
Yeah, but it is, but it looks just like Beal. So I totally get that, and okay. I probably didn't get yours quite right either.
No, you did a pretty good job with that. So, also we have Dr. Meghana Doniparthi, who's actually a GI fellow at Lutheran General Hospital where I work. So, Meghana, if you can just briefly give us a bio on you as well.
Sure. Hi, my name is Meghana. Thanks again for also inviting me to participate in the discussion of this article. I'm in my second year of GI fellowship now, and I think even in just my first year, I've definitely developed an interest in how diet and nutrition play a role in the development and, management of GI disease in general. And I think it's a very common question that patients have for us about what to eat. So I think it's nice to see this area being recognized as something where we need more high-quality trials to help us guide our patients.
And Meghana, I think it's, as a GI doctor in training, a lot of the listeners are going to be interested in your perspective. I think it is a great hospital to learn at, Lutheran General Hospital, because you have myself, Dr. Mark Fein, and other doctors who are interested in diet and IBD and do believe it makes a difference. And so I know as a trainee myself in residency and in certain parts of my training, it wasn't emphasized as much as I think it is now. So, and I was happy you decided to present this article during our journal club, and that's the way I got the idea for you to come on, and because you really delved deeply into this article. You know, before we start, I wanted to define both of the diets. So in case the listeners are not aware yet, the trial we're going to go over compares the specific carbohydrate diet to the Mediterranean diet. So to those who are not familiar with these diets, I just want to briefly go over the basics. Of course, there's a lot more than what I'm going to go over, the details about the diet, but it's good to have somewhat of a framework. So the specific carbohydrate diet is basically a monosaccharide diet, meaning there's no complex carbohydrates or lactose, but allows sugars like fructose and glucose. So what that translates to is fruits, vegetables, nuts, meat, legumes, beans that usually need to be soaked, 24-hour fermented yogurt, and that's a yogurt people tend to make at home from scratch, hard aged cheeses, dry cured cottage cheese, butter, no processed foods for the most part. Many additives are eliminated, and there is this big list of legal and illegal foods or ingredients. And the diet progression is based on symptoms. For example, if there's active diarrhea, you're supposed to limit certain things like eggs, a lot of honey, raw fruits and vegetables. And there are some foods that are considered more advanced that you don't necessarily start immediately. So that's the SCD. And then there's the Mediterranean diet. And I think there is a misconception that the Mediterranean diet means you eat a bunch of pizza and pasta. But that's actually not what it is. It's a diet modeled after diets of Greece, Spain, and southern Italy. And there doesn't seem to be a unified resource regarding officially what a Mediterranean diet is. I did go online and try to find such a resource. I did read through the Harvard website, the Mayo website. Ultimately, I took most of my information from a website called olivetomato.com, which seemed to be a pretty accurate place to get some information. So from there, I found that the Mediterranean diet is food mainly from plant sources, including fruits and vegetables, beans, nuts, and grains. Vegetables are the main course. Meat or poultry is a side dish and is not consumed daily. Food is minimally processed. The meals are made of vegetable-based, simple, home-cooked dishes for the most part. Local and seasonal foods are preferred. And olive oil is the main fat, replacing other fats and oils, including butter and margarine. I think that is one difference between the SCD and the Mediterranean, is that SCD allows butter and really any kind of cooking oil that you want besides soybean oil. But the Mediterranean diet is olive oil is very much emphasized, and extra virgin olive oil specifically. There's daily consumption of low to moderate amounts of cheese and yogurt, but it doesn't necessarily specify that they have to be lactose-free. So they do include soft cheeses as well, and the yogurt can have lactose in it. Weekly consumption of low to moderate amounts of fish and poultry, perhaps more of an emphasis on fish. And, eggs are allowed, but they try to limit that to 0 to 4 eggs per week. Fresh fruit is typically the dessert, and sweets with a significant amount of sugar, often as honey and saturated fat, should be consumed not frequently, maybe a few times per week. Red meat is allowed, but it encourages to limit that, maybe a few times per month. Moderate consumption of wine, normally with meals, about 1 to 2 glasses per day for men and 1 glass per day for women. And the whole thing about carbohydrates, now I think this is the main difference between the specific carbohydrate diet and the Mediterranean diet, is the issue with carbohydrates. Again, the SCD, no complex carbohydrates. The Mediterranean diet is still considered a moderate carbohydrate diet, about 40% carbohydrates, with moderate to slightly elevated fat. The most common carb is bread. Bread accompanies most vegetable dishes. And once a week, there will be a dish with pasta and rice. And that's often mixed with vegetables. So generally, it's something like 3 slices of bread a day or pasta once a week. Other grains maybe once or twice a week. So those are the basic ground rules of the two diets. Now, Kim, I don't know if you had any comments on that specifically about my description of the diets, or would you say that's generally accurate?
I agree. Yes, that's definitely very accurate and has hit the high points of the differences between the two. And maybe we'll discuss that later, but I do wonder if some of those components could make a difference, like gluten-free, dairy-free component or the fermented food differences. I think the olive oil point that you make is also a very good one. That I believe in Dine CD, they were actually required to even have a certain minimal amount of the olive oil daily. maybe Dr. Doniparthi can speak to that. But I remember having a discussion with Dr. Lewis about that I believe they, were required to at least have a tablespoon or so daily of that. So it's definitely an essential component of the Mediterranean diet.
Okay, and just to make this clear, none of us are authors on this paper. We are just kind of discussing it based on the information we're getting from the actual published paper. If by chance the authors of this paper listen to this podcast and want to have a rebuttal or say something about how we're describing the study, please do email me, and I'm happy to have you on the podcast as well, or at least put on social media whatever maybe you think we're getting wrong about the study. But okay, so Dr. Doniparthi, you can go ahead with presenting the study.
Sure, my pleasure. So the title of this study was a randomized trial comparing the specific carbohydrate diet to a Mediterranean diet in adults with Crohn's disease. Now, this article has been published online in Gastroenterology. It was published May 26, 2021, and we're going to dive into it now. So let's see. Okay. So the background of this study, I think, comes from, it's well recognized that the pathogenesis of IBD is influenced by a lot of non-genetic factors. And there are a number of modifiable risk factors which are being targeted for prevention and treatment in inflammatory bowel. I think one of the biggest areas of interest is the influence of the gut microbiome. And the mechanism here is that environmental factors can lead to changes in the microbiota composition, which can then lead to the loss of our nice, healthy mucinous layer overlying the gut epithelium, which can then lead to increased permeability, as well as exposure of our gut immune system to these antigens within the lumen. So from there, we have production of pro-inflammatory cytokines and potentially this loss of immune tolerance to our commensal bacteria. We have looked at how the microbiome can be manipulated by prebiotics, probiotics, fecal transplant, and diet. The theory behind dietary manipulation sort of centers around this reduced exposure to pro-inflammatory antigens and to also incorporation of anti-inflammatory components into the diet. So there have been some studies that have laid the groundwork for nutrition therapy in IBD, which, such as the use of exclusive enteral nutrition to induce remission, particularly in the pediatric Crohn's population. Beyond that, there was this review of the Cochrane database published in 2019, which looked at, I believe, 18 randomized controlled trials with around 1,800 participants, and they looked at the effects of a number of diets such as high fiber, low carbohydrate, low microparticle, symptom-guided elimination diet on the clinical remission in inflammatory bowel disease. And one of the findings was that around 50 to 60% were able to achieve clinical remission, but nearly half would relapse around 24 months. And they thought maybe relapse rates were lower in groups following the symptom-guided elimination diet compared to some of the other diets like low carbohydrate or the low meat diet. Now, we kind of went over the components of the Mediterranean diet and specific carbohydrate diet, but looking at the Mediterranean diet specifically, I would say just reviewing the literature, this is one of the most broadly kind of studied and recommended diets in general. And there was a recently published study in 2020 that showed an association between the Mediterranean diet and reduction in symptoms and improvement in quality of life after diagnosis in patients with Crohn's disease. And then even beyond inflammatory bowel, the Mediterranean diet has shown efficacy in cardiovascular disease, cancer, reducing inflammation. I
actually wanted to chime in here. So even when I was in training, it seemed like the Mediterranean diet was kind of the go-to diet to recommend just because it was like generally healthy, and there is data behind it preventing certain types of cancer, helping with obesity. I even in preparing for this podcast, I found a study where in ulcerative colitis patients who have fatty liver, a Mediterranean diet was associated with decreasing fatty liver, as well as they did see decreases in fecal calprotectin in patients on the Mediterranean diet. So I do think it is something that may be overall less difficult to follow compared to specific carbohydrate diet as far as all the subtle rules involved in it. And that may be one of the impetus to actually see if it was comparable to the SCD. I don't know, Kim, if you had anything to add at this point.
No, I'm glad that you mentioned those papers from Italy, the one in pediatrics from Naples showing the lower, greater adherence to Mediterranean diet associated with lower fecal calprotectin levels, and the paper from Lehigh Godney and Iris Doughton from Israel looking at pouchitis in ulcerative colitis, and the higher adherence to Mediterranean diet associated with lower fecal calprotectin levels and reduced recurrence of pouchitis. So certainly both diets are very good diets, and they offer great potential for patients with IBD.
Great. Okay, go ahead, Meghana.
Sure. So now looking at the specific carbohydrate diet, this was a diet, I guess, developed by Dr. Haas, but popularized by Elaine Gottschall in the book, Breaking the Vicious Cycle. And there have been some small studies that suggest the specific carbohydrate diet also improves symptoms and reduces bowel inflammation. And one of these studies done in the pediatric population showed that patients could achieve both endoscopic and clinical remission. I'm not that aware of other studies looking at health benefits beyond their use in inflammatory bowel.
Correct. Yeah, I think you're right about that. It's really been a diet used specifically for IBD, especially with respect to the publications so far.
All right.
Maybe of interest, there's a recent study with SCD, a researcher from Sweden, a pediatric rheumatologist that I've befriended in my continual tracking of ongoing dietary research. And she's Dr. Bernstein, and she's done a pilot study of SCD for juvenile idiopathic arthritis in a small population. And she has found improvement in symptoms as well as inflammatory markers. And that was just published this year in Pediatric Rheumatology.
Oh, great. And I am familiar with I think there's a trial by Dr. Korsnick who is going to look into the specific carbohydrate diet for PSC. I think that's in process. I'm not sure if you're aware of that study.
No, I'm not, but I will look for it. Thank you.
Yeah. Okay. So let's keep going.
All right. Now, I guess getting directly back into the article. So the aim of this study, as they stated, is to compare the effectiveness of the specific carbohydrate diet, which sometimes I'll refer to as SCD, to the Mediterranean diet as treatment for Crohn's disease with mild to moderate symptoms. And specifically, they say the hypotheses being tested here were whether the SCD was superior to the Mediterranean diet to achieve symptomatic remission, clinical remission, and reduction in biomarkers of inflammation. So this study, they titled the Dine CD, which is Diet to Induce Remission in Crohn's Disease. This was designed as a parallel group randomized trial comparing the Mediterranean diet and the specific carbohydrate diet. It was conducted at 33 sites across the U.S., and the enrollment period was between September 2017 and October 2019.
So what makes this study very important to the listeners who may not be in medicine or familiar with how research is done is that this is a randomized controlled trial, which is relatively rare to see in this sphere of research, of dietary research, just because it's so difficult to do. It's very expensive to do. So, and it is probably the highest quality study you can do, because randomization randomly assigns patients to one group or another, and that's supposed to get kind of level the playing field as far as all the unmeasured confounders that could lead to a benefit of one group over another. So that's why it's such an important study, precisely because it is a randomized controlled trial, which is, pretty much the best besides a meta-analysis, which I guess would be the top of the heap. But randomized controlled trial is considered, the strongest kind of evidence.
All right. So the inclusion criteria for this study were participants over age 18, patients with Crohn's disease established by endoscopic, histologic, and radiographic criteria, and patients with mild to moderate symptoms, which they defined by the short Crohn's disease activity index. And this uses abdominal pain, diarrhea frequency, and general well-being as weighted factors to generate a score. So for mild to moderate symptoms, they were looking for scores between greater than 175 and less than 400.
So Kim, do you have any comments about if you think this inclusion criteria was appropriate for this study? I mean, I do think it's always interesting why people who do dietary studies choose Crohn's or ulcerative colitis to study. I think, these type of diets, especially the SCD, tends to be a diet that's more Crohn's disease patients tend to respond better to. That's just in my anecdotal clinical experience. But it looks like they chose Crohn's, and they chose mild to moderate symptoms, but they excluded severe patients.
No, I agree with you. I think that's the appropriate, indication for it, or the place where it's considered most highly for use.
Right. I agree. I think if somebody's very severe, I still think there's value to doing diet as adjunctive, but they're going to need more aggressive, really mainly medication-based approaches. Okay, keep going.
Okay. So also they defined some exclusion criteria. Mainly this included patients with pregnancy, hospitalized patients, patients that had surgery planned within 6 weeks. They also excluded patients with known symptomatic intestinal stricture or ostomies. And they excluded anyone who had used the SCD within 4 weeks of screening. And then I think some of the other ones, BMI less than 16, they excluded BMI greater than 40, patients with celiac disease, recent C. difficile infection, diabetes, low albumin less than 2. And probably importantly, they created criteria for patients who are actively receiving pharmacologic treatment for Crohn's. So they excluded patients with any start or change in thiopurines, natalizumab, vedolizumab, and methotrexate within 12 weeks. Any patients with a start or change in their anti-TNF or ustekinumab or Stelara within 8 weeks of screening. The start or change in mesalamine or antibiotics within 2 weeks. Or start or change in corticosteroid dose within 1 week of screening. They also excluded people who were taking a steroid dose greater than 20 milligrams of prednisone. For patients who had recently discontinued their medications, there was a washout period prior to enrollment. This was a minimum of 4 weeks for thiopurines or methotrexate and a minimum of 8 weeks for biologics like natalizumab, vedolizumab, anti-TNF, or ustekinumab.
I did have one comment going back to the inclusion criteria. Reading in the appendix of the study, it seemed like they initially tried to include patients who had objective evidence of active disease. like that they were targeting those patients initially, which is what you should do, because there are patients who have symptoms and don't have active disease, and it may be more in line with kind of like just irritable bowel, even if they have like a healed bowel. But I think they had recruitment issues where they were not able to get enough patients, so eventually they loosened that restriction and just went symptom-based and kind of did sub-analyses on the patients who actually did have active disease. So that is an important point, that not everyone that was enrolled had active disease or had at least objective evidence of active disease. Okay, go ahead.
All right. So getting into some of the methods, we talked about this was a randomized trial. So they had computer-generated randomization after the patients were stratified by current use of biologic drugs. So they were then randomized in a 1-to-1 ratio to the Mediterranean diet or a specific carbohydrate diet. And the allocation itself was blinded. And so for the first 6 weeks, participants were actually given prepared meals. So this included breakfast, lunch, dinner, and 2 snacks per day. For women, this was about 2,500 calories per day, and men 3,000. But the participants were not required to consume all of the food that they were given. And the individuals in the specific carbohydrate diet group did receive a 3-day starter diet that is based on, which is what is described in Breaking the Vicious Cycle. And after 6 weeks, the participants then had to prepare their own meals and snacks, but they did have access to meal prep websites and also the assistance of a dietitian.
So this is another thing that makes this trial very unique, is that at least for those first 6 weeks, we know exactly what the patients were eating. At least the study, the people who did the study. So that is quite unique. Instead of relying on patients to learn about the diets themselves and come up with recipes, which can be a barrier, here they just sent the meals and snacks directly to the patients. And so that's a big strength here.
Definitely. And yeah, some of the data at the end comparing between the first 6 weeks and the between week 6 to 12 probably take into account participants preparing their own meals versus giving pre-prepared meals. But okay, so the participants were also screened for inflammation during enrollment. Specifically, they used a high sensitivity CRP with level over 5 milligrams per liter, and fecal calprotectin over 250 micrograms per gram, and then also the documented presence of inflammation on endoscopy in 3 months before screening, if that was available. So they did not have to undergo endoscopy. It's just if they had it done, and those reports were available to review. So getting into the outcomes, the key outcomes were measured at after weeks 6 and 12. The primary outcome was symptomatic remission at week 6, and this was defined as short Crohn's disease activity index scores less than 150 in the absence of initiation or increase in any Crohn's disease medications. So that was their primary outcome. The secondary outcomes included a fecal calprotectin response, which they defined as a reduction to less than 250 and by greater than 50% from screening, and a CRP response with reduction to less than 5 and by 50% from screening. And I had to look up, I think a normal high sensitivity CRP level is less than 2.
Yeah, I wonder why they chose high sensitive CRP instead of regular CRP. Maybe it's not really used in clinical practice. At least when I was in training, it was more used for like cardiac disease, to monitor that. But I did look it up, and I guess there is some data validating its use in Crohn's. Maybe it's something that you'd be more sensitive to seeing differences. I'm not sure the rationale, but I know Kim you had some comments, right, about these particular outcome measures.
Well, I think you've kind of already alluded to that in the supplement material that describes that. I think that was the initial plan, was to select patients that did have evidence of inflammation, either by these markers or by endoscopy. But I think that, as I described, they really had a difficult time with, I think, only 4 to 6 patients enrolled at 6 months. And so when those criteria were loosened, really only 47% of the patients had any evidence of inflammation. So it does make it more difficult to evaluate the effects on inflammation when you don't have a population that has high levels of or evidence of elevated inflammation at baseline.
Right. And also, I think you made we exchanged an email about this study, and it's relatively stringent requirements for a fecal calprotectin response and a CRP response, in that it has to be, as far as fecal calprotectin, has to be less than 250, and it has to be greater than 50% decrease from screening. So it's not like one or the other. You have to achieve both of those benchmarks in order to be considered a responder.
Mm-hmm. Exactly, which that leaves, and it's really it's far more stringent than what you see in most trials, including pharmaceutical trials. And so I think it's really difficult to achieve in a population that the majority don't have elevated markers, and then the ones that do have some level of inflammation, and if you look at the range, it's mild, to have to achieve such a high threshold to meet a binary endpoint of having both reduction less than 250 for fecal calprotectin or less than 5 for CRP, and a greater than 50% reduction. So, for example, something that might be clinically meaningful, such as a fecal calprotectin of 400 achieving 220, or a CRP of 8.5 moving to 4.5, that would simply not be included as a response according to this criteria.
Right.
Okay. Let's keep going.
Okay. So other outcomes of interest that they measured at weeks 6 and 12 included the full Crohn's disease activity index score. So this one includes hematocrit, use of antidiarrheals, body weight, extraintestinal manifestations. And then they also looked at the 2-item patient-reported outcome remission, which is abbreviated as PRO2 remission, which looks at the mean daily liquid or soft stools and abdominal pain. They also were interested in identifying the participants that had combined symptomatic remission and a fecal calprotectin or CRP response, or the combined PRO2 remission with fecal calprotectin or CRP response. They did also use patient-reported outcomes measurement information system to record information on fatigue, social isolation, pain interference, sleep disturbances, so really important factors in quality of life. They used the RAPID-3 scoring system for measuring arthritis symptoms. And then the Bath ankylosing spondylitis functional index in patients with inflammatory back pain scores of 4 to 5 out of 5 on screening. So they were really collecting a lot of important information on other important measures in inflammatory bowel. They did also measure diet adherence at weeks 3, 6, 9, and 12. By having patients self-report whether they were following the diet all of the time, some of the time, or none of the time. And they did record 24-hour dietary recalls at baseline, week 6, week 12, to calculate the alternate Mediterranean diet score, where a higher score equals a greater consistency with the diet, and the healthy eating index, where a higher score correlates with a healthier diet. They also performed stool microbiome analysis with DNA extracted from stool samples for sequencing. They looked at certain measures like alpha and beta diversity and richness. And alpha diversity is this measure of the microbiome diversity in a single sample, and beta diversity is a measure of sort of the similarity or dissimilarity of the two communities. And richness was assessed as the number of species.
Meghana, do you have an idea? I had trouble finding this in the article, but how many people actually submitted stool samples? Was it everybody, or is it just a subset of the total group?
Oh, that's a great question that I don't think they specified from what I remember in reading the article.
Right. Yeah, I didn't see it either. So
I guess I assumed that it was probably a stool sample from everyone, but that is maybe an incorrect assumption.
Okay, I guess we just don't know. All right.
They actually, looking at the article, say they have more details in the supplementary methods, so it could be in there.
Okay. I'll look into it later.
So finally, last part of the methods, their power calculation. So they estimated that with 97 participants per group, their study would be powered 80 to 90% to detect a 20% absolute difference in the effectiveness of the two diets.
And they had a comment about that power calculation, which generally means calculating how many patients they need in the trial to detect a 20% difference. And they suggested having a 20% difference, like less than a 20% difference in the effectiveness of this diet, is probably not worth following a diet as strict as the SCD compared to the Mediterranean diet. So that's how they picked that 20% number, kind of just arbitrarily. From my understanding of the article, was that they felt like less than 20% of a difference doesn't justify for most patients having to follow such a strict protocol like the SCD.
Right. I thought that was a really interesting point that they included. All right. So now getting into the results. So they screened about 460 participants, and of those, actually 93 received the Mediterranean diet and 101 received the specific carbohydrate diet. Looking at the follow-up, 33 participants withdrew or were lost to follow-up before week 6, and then 37 withdrew between weeks 6 and 12. The baseline characteristics of the participants, they made some interesting notes. Overall, 63% were women and 91% were white. The median BMI at the time of screening was 25. And the median age at randomization was pretty even between the two groups, age 36 for the SCD and 37 for Mediterranean diet. And with the median years since time of diagnosis being 10 years for both groups.
Meghana,
overall,
do you know if the patients that dropped out, were they still included in the analysis later on, or were they just excluded? Like, was it intention to treat or per protocol analysis?
Let me see if they mention this in the article. May be able to find it later, but I don't know if they included it in their results section.
Okay, I guess we could probably tell by the tables, but I mean, it's always a strength to have intention to treat analysis, meaning if a patient drops out, to still include them in the analysis, and that it gives you more of like a real world data. But I actually think in this type of study, doing a per protocol analysis would be better, given that these, just to be real, like most patients don't want to follow, or maybe they do, but it's just not possible for most patients to follow strict protocols. At least in my experience, I pretty much all of my patients, I give them these dietary options, and it's the minority that actually have the interest to do it and follow through with it. So it could be that this management strategy is more appropriate for that small subset of patients who are willing to do it. And to include kind of all comers into the analysis I mean, sure, it may diminish the efficacy numbers that you get at the end of it, but still, I wouldn't want that to tarnish the numbers for those few patients who do stick with it, even though in this study it seemed like most people did stick with it.
It does. They did say that for most of the analyses that they did follow intention to treat analysis. So all people who are randomized were included.
That was my understanding as well from reading it. But I think there was a comment made towards the end, maybe it was in the supplemental discussion, where they said they did also analyze it, excluding patients that did not follow it closely, and that they did not find a difference, but we don't actually have any data for that, is what I recall.
I see. Yeah, I think I remember reading something similar to that. Okay, got it. Let's keep going.
Okay. So, looking at the baseline characteristics, it looks like overall 61% of the participants had non-stricturing or non-penetrating Crohn's. And in looking at disease distribution, around 57% had both ileal and colonic Crohn's, while I think 27% of the patients had disease of the ileum alone. Also, at the time of screening, overall 57% of participants were taking biologics, and actually 67% had used one or more anti-TNF agents, and then 11% had used three or more. It's kind of a diverse mix of participants. 47% of the participants had confirmed inflammation at baseline, so this was either with the CRP greater than 5, fecal calprotectin over 250, or the documented inflammation on colonoscopy. There was a slightly higher number of people assigned to the SCD group that had an elevated CRP or fecal calprotectin compared to the Mediterranean diet. And the median fecal calprotectin in the SCD group was 107.5 and 40 in the Mediterranean group. Those were some of the kind of interesting patient characteristics I picked out. I'm not sure if any others stood out to you both.
Well, it seems like none of the patients were. It seems like all the patients were taking medication. There wasn't a single participant who was taking no medicines, from what I could see from the tables. Is that right?
I thought it was 70% had experience with, or maybe that was an anti-TNF.
Yeah, because this table that says current IBD medications, there is no category for no medications. So it seems like, from what I can tell, everyone was on some kind of medication, but the assumption is they felt like it wasn't working, right? They had been on it, no changes were made, and they were still meeting this inclusion threshold of having symptomatic disease and potentially inflammation.
Which is a great point, because, when you get to the results part, it's very interesting to see the effects that you can get, even in patients who, have been on therapy and have really not achieved their goals for symptoms or inflammation. The dietary therapy can make a significant contribution.
Right. I mean, 57% were taking biologics, which are considered to be some of the most potent medications, and despite this still having symptoms and inflammation, to expect diet on top of that to have an effect is really remarkable. So, okay.
So getting into the primary, secondary outcomes at week 6 of dietary therapy. So the percentage of participants who achieved the primary outcome, which was symptomatic remission, at week 6 with the SCD group was 46.5, and in the Mediterranean group, 43.5%. So fairly close in number, and the p-value here was 0.77. Of the participants with an elevated fecal calprotectin at screening, the fecal calprotectin response was achieved in 34.8% in the SCD group and 30.8% with the Mediterranean group. The change in the fecal calprotectin, which was a median reduction of, I believe, 140 in the SCD group, was statistically significant there. So that p-value was 0.0001. But looking at the comparison between the groups, there was not a statistically significant difference in the fecal calprotectin response when comparing the Mediterranean diet to the specific carbohydrate diet. Also among the participants that had an elevated CRP at screening, response was achieved in 2 out of the 37 participants, or 5.4% in the SCD group, and 1 out of the 28 participants, or 3% within the Mediterranean diet group.
I mean, to me, these are very impressive results, at least the week 6 results, regarding the percentage of patients who had symptomatic remission, over 40%, fecal calprotectin response, roughly, 30% or so for each group, especially in a patient population that were on meds, not working. I mean, these are dramatic numbers to me. And I know you said the only statistically significant one was fecal calprotectin response in the SCD group. Is that right? From baseline correct. To week 6. So yeah, I mean, comparing the magnitude of these results compared to what we usually see in medication trials in similar patient populations who have experienced a lot of different medications in the past. Like, for example, if you look at the trials for ozanimod, for example, I know we're talking a different disease state, an ulcerative colitis, or even Xeljanz, or the newer biologics. You don't really see. I mean, it's at least similar magnitude here, and maybe even better in some circumstances.
Yes, and particularly given the stringent criteria to define that response, I think it's particularly good.
Yeah, I think if you just look at this trial superficially and don't get into the details, it can be easy to just say, oh, like the SCD is no different from the Mediterranean diet. But I don't think it was really emphasized this point. I mean, it is clearly stated in the article that there is this fecal calprotectin response that's better than placebo and better than or statistically significant from the start for SCD specifically. And I know later on they say at week 12 that wasn't significant anymore. But another thing to keep in mind is that from week 6 to week 12, they weren't getting their meals delivered anymore, and they were kind of on their own. So I don't know if that had some influence or what. But and also, if you actually read Breaking the Vicious Cycle, it's not uncommon to have a flare at month 2 or 3 when you're on the diet, if you really go by kind of like the old school interpretation of the diet, which is, you can get a cold or some viral infection a few months into it, and you can slip back. And it's very common for patients on the SCD to have these hiccups. It's usually not a straight line trajectory. You tend to get better. You have a little bit of a setback. You make some adjustments. You get better. So I don't think those subtle things that are very well known in the SCD community were really taken into account.
Well, and I'd like to ask again, and maybe you remember more precisely, Dr. Doniparthi, but I believe at 12 weeks, there was a wider numerical difference between them, 7% versus 26%, that right. I don't think that the statistical significance is reported from baseline, only the statistical difference between them, which is 0.2. Knowing again that it's more difficult to show statistical significance between than it is from baseline, because I think it's an important point even for the symptoms category that both diets from baseline were highly statistically significant from baseline, 0.0001, I believe. And then furthermore, there was no difference between them. So that really sort of emphasizes that when it comes to symptoms, that these diets, both of them, clearly improve symptoms to a similar degree, but because of the disparity from baseline, when you look at inflammation, that seems to be a difference.
Great point.
Yeah, I think that is a point too. And I guess when we talk about the week 12 data, we can see what they've reported. But let's see. To kind of finish up with week 6, so looking at the rates of participants that achieved the secondary outcomes, so this was looking at symptomatic remission with a fecal calprotectin or CRP response. From the table that they've reported, it looks like there was not really a significant difference between the two groups. Overall, the combined symptomatic remission plus fecal calprotectin response rates were 26.1% with the SCD group and 7.7% with the Mediterranean diet. So although it's not statistically significant here, the p-value is 0.25, there is still this 26.1% of patients in the SCD group that did have a combined remission with fecal symptoms plus fecal calprotectin, which I thought was still a big number. All right, now looking at outcomes after 12 weeks of dietary therapy, and then also we talked about this is when participants had to prepare their own meals for the last 6 weeks as well. Looking at week 12, the percentage of patients who achieved a symptomatic remission was 42.4% with the SCD and 40.2% with the Mediterranean diet. So about a 2.2% difference there. And comparing this to week 6, this is maybe a 2 to 3% decrease in the symptomatic remission rates. The p-value here as well is 0.87. Of the patients with the elevated fecal calprotectin at screening, the response was achieved in 26.1% of participants with SCD and 7.7% with the Mediterranean diet. And looking at the CRP response, this was achieved in 10.8% with the SCD and 7.1% with the Mediterranean diet. And I actually noted that that CRP response rate was higher at week 12 compared to week 6.
I thought that was interesting too, since compliance might be slightly less. An interesting point.
Yeah, I wasn't really sure what to make of it, but it was interesting. And then I noted here that this wasn't really included in the figures or the tables, but in the text, they reported that there was a clinical remission. Clinical remission at week 12 was achieved in 40.4% with the SCD and 46.7% with the Mediterranean diet. But I didn't really see any further details after that statement. All right, and then looking at the rates of achieving the secondary outcomes at week 12, among the patients who had a fecal calprotectin response at week 12, 3 out of 6 also had symptomatic remission compared to 0 out of 1 on the Mediterranean diet. And then similarly with CRP, combined symptomatic remission rates were 4 out of 37, so around 10% with the SCD, and 1 out of 28 with the Mediterranean diet. They did also include, this is figure 4 in their study, that they did a stratified analysis to look for treatment effect heterogeneity based on different variables. And some of these include confirmed inflammation, duration of Crohn's disease, disease involving the colon, biologic use during the study, if they'd had intestinal surgery before, steroid use, adherence to the diet. So a pretty interesting figure. And in 88% of in 88 patients with the confirmed inflammation at screening, symptomatic remission was achieved in 48% with the SCD and 50% with the Mediterranean diet. So almost half of the patients with inflammation at screening had symptomatic remission. In those without inflammation, symptomatic remission was achieved in 46% with the SCD and 40% with the Mediterranean diet, so very similar results there. And then they didn't find any significant treatment effect heterogeneity with the other variables like duration of Crohn's, colonic involvement, or use of biologics.
I think that's such a good point that you make, that regardless of whether inflammation was present, a good percentage of patients found improvement in symptoms, 40-some% in both categories. And that's really amazing, as I know Dr. Kakodkar pointed out, that on top of biologics, et cetera, and some with 10 years duration of disease. So it's really important. It's really meaningful.
Yeah, and feeling good is also important. We tend to focus so much on inflammation and addressing inflammation and healing the colon, but in reality, oftentimes it's not possible. There are lots of patients out there with IBD who are living with low-grade ongoing inflammation that no matter what you do, diet, medication, or everything you can try, it doesn't completely heal the colon. That's just the reality, that sometimes you can't get there. And so feeling well, especially in those cases, is very important, even if you don't get to the underlying inflammation, just so people can function and work every day and do the things they enjoy. And that's what it's all about. It's about quality of life. Sometimes we just get so narrow-minded and saying, oh, it's not addressing the inflammation. But it is an option even for those patients who have a healed colon and they're still not feeling well. And I know there's data for the low FODMAP diet as well in IBD patients to improve symptoms, but not necessarily inflammation. But it seems like both of these diets, not surprisingly, would also make people generally feel better.
And fatigue, I'd like to mention, because that's on a separate list than the Crohn's disease activity index, and it's not commonly reported in trials, but it was in the patient-reported outcomes survey. And fatigue is such a common problem, disadvantaging the quality of life for patients with IBD. So to be able to improve that statistically significantly is really a big deal.
Yeah, I agree. I'm going to start with supplemental table number 1, which is the change in symptoms from screening to week 6. And I know I wrote down on my article, very important finding. So looking at this table in the supplemental index, they do have this data regarding change in symptoms. And looking from from screening to week 6, there was improvement in some of these indices, like the short Crohn's disease activity index, the full Crohn's disease activity index, IBD-Q scores, and then also looking at fatigue, sleep disturbance, pain interference, social isolation. All of these were statistically significant in both arms. And so although the magnitude in change between, the SCD, it was not superior to the Mediterranean diet, both diets had a significant improvement. So I think that's very important.
The subcategory of social isolation is interesting to me because on the one hand, restrictive diets can make you more socially isolated because it's hard to eat out with people, it's hard to travel, it's hard to socialize. But on the other hand, if you have active symptoms, it's also difficult to do those things too. So I think sometimes the resistance to recommending these diets can be, oh, it's so strict, oh, it's going to ruin your social life, oh, it's not realistic. But it seems like on balance, the actual improved quality of life makes people less socially isolated despite the restrictions in the diet.
Exactly, and I think that's interesting because that's what they found out with EEN, even because that was assumed that for those same reasons, it would be decreasing quality of life, but patients, because they felt better, actually reported improving quality of life.
Let's see. All right. So also looking at other symptoms, the back and joint symptoms. So this is supplementary table 5. Most patients here did not have severe back or joint pain at the time of enrollment. And they found that there was really no difference between the assessment scores at week 6 or 12 between the two diet groups. So I sort of kind of skip over this table. Next part, which I find really interesting, is adherence to diet. So they reported that adherence all of the time in week 6 was 68% of the SCD group and 64% of the Mediterranean diet group. So I thought that was actually pretty good. And of those patients, 52% in the SCD group and 49% in the Mediterranean diet group achieved symptomatic remission. So if of the people who were adherent all of the time, about 50% had symptomatic remission there. There was a similar comparative effectiveness at the other adherence levels as well, though. And then looking at week 12, this is when participants had been preparing their meals for the 6 weeks prior. Adherence all the time here was 40% in the SCD group and 42% in the Mediterranean diet group. So about a 20% decrease in all of the time adherence. For both groups, though, there was a significant increase in their consumption of fruits and vegetables from screening to week 6, and those scores that they calculated had increased in both groups.
This adherence data was surprising to me because it doesn't really seem like the Mediterranean diet or people on the SCD were less adherent than the Mediterranean diet. In the discussion of this paper, pretty much their conclusion was that since there isn't a statistical difference between the diets and their primary outcomes, that probably it's better just to recommend a Mediterranean diet because it's easier to follow. But despite that, and I do agree with that in theory, that the Mediterranean diet's probably easier to follow because of less restrictions. You can eat grains, and grains really open up a lot of possibilities, ease of cooking and traveling and that type of stuff. So, but based on this data, it seems like there were similar adherence rates to both diets even at week 12.
Mm-hmm. Yeah, I thought that was interesting too, and they mentioned that participants did have the option of purchasing prepared food from it's called Healthy Chef Creations, and I think 15% of the Mediterranean diet, and it looks like 8% of patients in the SCD group chose to order their food from this service. But yeah, it seems interesting that adherence is pretty similar.
I think another good point to make is that, sometimes people get caught up in these diets of, it has to be perfect. But I found it kind of encouraging. As you mentioned, compliance was around 70%. So even if it's good but not perfect, you still see a substantial benefit in improvement in symptoms.
Mm-hmm. That's a good point. Okay. Now looking at the microbiome analysis, which I was interested in, showed that there was a pretty comparable richness between the two groups, and there was no significant change in diversity over the course of the study. They did find that there was an increased relative abundance of Bacteroides and then a decreased abundance of Firmicutes. And from what I know, Bacteroides is one of these strains associated with leanness, and Firmicutes can be associated with obesity and other conditions. Neither alpha nor beta diversity at screening or at week 6 was associated with achieving symptomatic remission, even after adjusting for the assigned diet.
This was also a little bit eye-opening for me, is that they didn't really see any association between these the diversity measurements they were using and actual outcomes. So to me, it's like, are we emphasizing this microbiome aspect of therapeutics a little bit more than we should? Is it really that important? And I have a theory regarding the microbiome, specifically in Crohn's disease. I'm not sure if it's really been established that shifting the microbiome back to a normal state is necessarily associated with better outcomes in Crohn's. I could be wrong, but I think we know that in ulcerative colitis and Crohn's disease that Bacteroides and Firmicutes are lower, and that overall the diversity is less. But specifically with Crohn's disease, we know that exclusive enteral nutrition works, and that we know decreases the microbiome diversity. We know that antibiotics work, at least in the short term. Those decrease microbiome diversity. So do we really know if shifting it back to normal, especially when the patient now has a dysregulated immune system, and potentially a disrupted gut barrier, does shifting it back to normal necessarily mean that things are going to go back to normal? I don't think we know that yet. So it's still a lot needs to be learned about the microbiome and what these measures really mean with regard to real clinical outcomes. I published, I did some analysis a few years ago on SCD patients who are in remission on the SCD, and saw that they had more lacnospira in the stool samples, and it was associated with a decreased fecal calprotectin. But still, even that was preliminary data, and we don't really know what all this means.
All right. And then finally, looking at the adverse events, as we've kind of talked about, both diets were pretty well tolerated. There was a slightly higher number of reports of adverse events in the SCD group compared to the Mediterranean diet group at week 6 and 12. The majority of the reports were gastrointestinal, and looking a little bit deeper, it says that the most common report was abdominal pain. So I'm not sure if that's necessarily an adverse event of the diets. And I think that concludes my kind of results discussion, unless anyone else has anything else to add.
I had a few comments. These are just kind of subtle things that I picked up on the study. I did look through the sample diets. Like, they have a table, I think, of 7 days of a sample diet for each for the Mediterranean diet and the SCD. And technically, I personally don't think these things are that important, but for some of the SCD adherents, the people who say, oh, you need to be fanatically adherent and follow what the book says, there were technically some violations. Like, for example, if you go by the book, you're not supposed to introduce fruits, or you're not supposed to have like raw fruits, vegetables, if you have active diarrhea. And by day 4 of this diet, sample diet, they had fresh raw veggies and like fruit plates and stuff. So, and you would assume by then, and who knows if they really resolved their diarrhea within those 3 days of the starter diet. And so there's certain subtleties in the STD protocol that they didn't necessarily follow. Also, they included like pumpkin seeds pretty early on. Are those considered more advanced foods according to some people? Also, you're not supposed to have a lot of eggs with active diarrhea. So those were I think I covered a lot of my other comments. Oh, the other thing was, I think the main difference between these diets, is the grains. Otherwise, they're pretty similar. Sure, the lactose and the dairy, that's another major one. How you cook, like the oils, olive oil versus really any oil you want, besides soybean oil, but pretty much all the oils and butter is allowed on SCD. But grains, I think, is the thing most people are interested in. And if you look at the menus, there's several meals in the Mediterranean diet that have no grains whatsoever, at least what it looks like. I mean, I don't have all the ingredients for all of these meals. I just have the name of the meal. So from what I can tell, it's relatively rare to have grains. Like they have sandwiches sprinkled here and there, some wraps, which I would assume is like a tortilla wrap. I saw quinoa and rice in a few of the meals. But there are several meals that look pretty similar to the SCD as far as what's allowed. So I'm actually not surprised that they didn't see any difference. And personally, I was really rooting for there to not be a difference. As somebody myself who's followed the SCD, I followed it strictly for about 7 years, and over the last 4 or 5 years, it's been different sort of variations, but pretty much sticking relatively closely to the SCD. I was hopeful that this would be that there wouldn't be much of a difference at all, which it seems like that was their finding. But numerically, it seemed like a lot of the outcome measures favored the SCD, although it wasn't statistically significant between them. So what I wonder with this trial is if there's, based on these findings, if there are people on the SCD, are they suddenly going to say, hey, I'm done with this? I'm going to start eating grains. I'm going to start eating quinoa, rice, bread, whole grain bread, avoiding the processed stuff still. But that can open up a lot of possibilities. And then also eating the soft cheeses, eating the, I think those are the main differences. And I don't know. I would be curious to see, and that may be actually a good trial. Get some of these patients who have been on strict SCD, have been doing well, cross them over to the Mediterranean diet, and then see if there is a difference in their inflammatory markers.
Yes, I agree that the gluten-free, the grain aspect is really, really important to study more. I mean, we really haven't had much research at all in patients with IBD in terms of the gluten component. There's really only been like 1 or 2 papers, and the one from Herfeth showing, improvement in symptoms. But really looking at the immunology of what happens with the gluten and its effects on zonulin and intestinal permeability, that I do think we learn more by looking across other autoimmune conditions, like the recent publication in children with kidney disease, that steroid-resistant nephrotic syndrome, looking at a gluten-free and dairy-free diet, and they showed a highly significant reduction in inflammatory markers, and both at the cellular level and the protein level, and as well as a change in gut microbiota. So I think we really do need to dig in a little bit deeper in terms of the grain aspect and what impact it has immunologically in patients with IBD.
Great. So Kim, did you have any other comments? Otherwise, I do have questions from the audience that I can, just a few that were submitted through Facebook and Twitter, that I can go over next, and you can chime in if you have any comments on those. But any final comments on this study? I think from my perspective, I think it's very encouraging results. It seems like it is decreasing inflammation, both diets. I would say both diets are options. I agree with the discussion in the paper that says if there's a patient who wants a more structured approach to this, with a little bit more guidance and specifics regarding the diet, the SCD may be a great option. I like SCD and the IBDA diets for Crohn's disease, but I would say does this trial change my practice? Yes. I think if someone wants to do Mediterranean diet as well for Crohn's disease, I'm up for it. I'm totally up for it, and I think this data supports that. And I don't think it should be lost that this is just a trial showing that there's no difference between the diets. Another emphasis is that they seem to be effective, in my opinion.
No, I agree completely that, we as an organization really support both diets, and we're really working on some new clinician resources to help clinicians to personalize and to meet patients' needs, and that can be done simply by offering increasing fruits and vegetables or offering Mediterranean diet. but we don't want to eliminate, based on this trial, the offer of a therapeutic diet for those patients that might really be interested in taking additional steps that may, provide them additional benefits. So we don't want to push them toward or away from a therapeutic diet based on this research. We really want to be all-inclusive of all of those factors, increasing fruits and vegetables, Mediterranean diet, and therapeutic diets as all good options to help improve the lives of patients with IBD.
And I feel like what's obvious is that everybody's different. Every Crohn's patient, every ulcerative colitis patient is different with regard to their dietary tolerances, intolerances. So if somebody's on SCD and they decide, okay, I want to transition to a Mediterranean diet, but in the past when they've tried to eat grains and felt worse, that's a complex situation. Is that inflammation? Is it just symptoms? Do you just push through the symptoms and continue to eat that food, knowing, given this data, and just see if things get normalized? Because some of those symptoms may just be your bacteria in your colon getting used to a new food, not necessarily, the inflammation getting worse. So it's a hard thing to navigate when you're on kind of a diet you're used to and transitioning to a new one with the goal of improving your quality of life. Meghana, did you have any comments before I get to the questions?
No, I think I had a very similar perspective on this, especially being really new to now counseling people on nutrition or diet. My sort of takeaway was that, maybe it's not a bad thing that there was no significant difference between the two. I think what I took from it is that maybe counseling people on eliminating processed foods, focusing on fresh or whole food consumption, can that by itself can improve their symptoms, and maybe not being so afraid of fiber in our IBD patients as well.
Right. Okay, so let's go to the questions. One listener asked, could it be that any diet that eliminates gluten and dairy and is just generally healthier, like paleo, vegan, SCD, Mediterranean, can be effective? From my perspective, I think the jury's still out on if gluten itself is a problem for IBD. I mean, it's more obviously a problem for celiac disease and non-celiac gluten sensitivity. But with respect to IBD, theoretically, it may contribute to more of like a leaky gut type of physiology, but we don't know. But yeah, as Meghana said, I think basically diets that eliminate processed food and tend to be more plant-based are the ones, is pretty much the commonality amongst these diets. Anybody else with any comments on that? No? Okay. Let's go to the next question then. The Mediterranean diet generally encourages a diet of lots of whole grains. Did the participants on the Mediterranean diet follow a gluten-free diet? From what I could tell from the menus and from the discussion in the paper, it doesn't seem like they made an effort for it to be gluten-free. No. Assuming they did not, did they eat whole wheat bread, pasta, rice? Well, from the sample menu I saw, it seems like there was rice, quinoa, wraps, sandwiches. I didn't see a lot of pasta, but we were only got 1 week of a sample menu. Could there have been pasta in subsequent meals? I think probably. Although, as I said, classically a Mediterranean diet is pretty much 40% carbohydrate, so it's not like tons of pizza and pasta. It's actually not the predominant part of the diet. It's more fruits, vegetables. Was yogurt part of the Mediterranean diet, sample diet? Yes, it was.
Yes.
And it was not necessarily lactose-free like it was on SCD. And then also asked, were soft cheeses like mozzarella and fresh ricotta included in diets in limited amounts? Yes, I did see cream cheese in the sample menu on the Mediterranean diet and manchego cheese, but it was in limited quantities. It wasn't like a lot of it. And then can you provide any information about the type of IBD that diet appears to be most helpful? Thanks. Kim, do you have any insights on this, given all your experience looking at all the other trials done in IBD? Is there a particular type, ulcerative colitis, Crohn's disease, and even subtype of Crohn's or ulcerative colitis that tends to be more diet responsive according to the data?
I don't think so. I mean, I think that initially, there's been a thought for maybe Crohn's disease to be more responsive to diet. But, given that there's more and more data coming out in patients with UC, like Dr. Brew's study with increasing fiber, high fiber in patients with ulcerative colitis, and those patients, even in remission, saw a benefit. And there's the ongoing trial now of SCD versus Mediterranean diet in UC patients that, and the prevailing pathophysiology is maybe not all that different, between the different disease states. So I think there's a lot of reason to believe that it is equally effective in whether you have Crohn's disease or ulcerative colitis, but I don't think it's as well studied.
Oh, I wasn't aware that they're doing this also for ulcerative colitis. Is it the same study group who's doing it?
Different study group. And we do list it on our website under ongoing research. And they do have an enrollment link, and then they would love if anyone would be interested to participate, because they are just now beginning enrollment for that trial.
Is that a similar study design where they're getting meals shipped to them?
I don't remember actually the details of that. I'd have to reread that.
But is it done in the Is this being done in the U.S.?
Yes, it is. It is. And I can't quite remember if it's at UMass. I think it might be either at UMass or at Harvard. Massachusetts. I think it's at Massachusetts General, actually.
Okay.
That's doing this trial of SCD versus Mediterranean in UC. So we can look forward to that.
Okay.
And we can also help with recruitment, because they're just getting started, and I know that they would really appreciate more patients to become involved. So we can help answer that question.
Great. My prediction, and of course I could be wrong, is that I don't think the diet is going to work as well in ulcerative colitis. That's my gut feeling. I'd be curious to see what the results will be. Okay. And next question is, was an intro diet followed? Yes, they did follow the intro diet for 3 days. The whole thing about, different preparation of eggs and, dry curd cottage cheese, and, pretty much the typical intro diet was followed for 3 days. And did they completely avoid advanced food since the study only went 12 weeks? No, I think there were some violations in that, as I had mentioned earlier. Did people report on what they ate after the first 6 weeks, and is that info available? It wasn't available in the study as far as the specifics, but we do know the relative adherence to the diet, but we don't know specifically what people were eating. People who just start the diet are used to others prepping their food and are usually not great at following the diet, introducing food slowly and eating a variety of foods. I'm skeptical of how well people did following the diet on their own. It seems like, Meghana, what were the numbers again as far as the adherence to the diet from week 6 to 12? They were still pretty good, right? At least it was self-reported.
All of the time, it was still 40% and 42% compared to 68 and 64. So still pretty high adherence for all of the time.
Okay, and they did like a subgroup analysis based on the people who are all of the time adherent, right? And they said they found similar findings.
Correct.
Okay.
Yeah.
Did any of the other patients have other autoimmune disease? I don't think we have that information, right? They didn't list other comorbid conditions.
No, that was not included in the baseline characteristics.
Okay. Another listener said, I'm a therapist and have had UC for 15 years. As I've been following the discussion of diet for IBD more closely, recently I've noticed I sense a similar feel to the debate around tailoring specific psychotherapies to various disorders, like EDMR for PTSD, DBT for bipolar disorder, cognitive behavioral therapy for depression, etc. When researchers do meta-analyses of these different treatments, they consistently find that therapy is helpful and has better results than no therapy. They also find that the differences between therapeutic approaches are pretty minor. Could something similar be going on here? Is it that the specifics of the diet are not as crucial as the fact that we are not eating a Western diet? Is it the intentional awareness that we are bringing to improving our diets, regardless of the particular protocol, in which case it becomes very important to ask if this particular diet instills hope and can help me engage in a process of positive change, rather than it being the true diet. In the end, though, we won't stay engaged in a process unless we see or feel some positive changes in our lives. Just some thoughts. I think that's very, very wise comparison there, and I do think there's a lot of parallels with respect to what you're describing, and that I also believe the details of the diets don't matter, besides taking out the processed food, being relatively plant-based, which is pretty much going away from a Western style of eating. And I don't know if, Kim, you have any comments on that?
No, I agree with you. There's a lot to be said for just taking the small steps, and I think that that's what we want to work towards as an organization, because I think it can be overwhelming when people think that they have to do absolutely everything as a therapeutic diet, all or none, when there's a lot of benefit that can be achieved with small steps, decreasing sugar, decreasing processed or eliminating processed foods, and increasing fruits and vegetables. So that's a new resource that we're working towards to really encourage steps along the way, because we find that may be actually the most helpful to people, because it's less daunting when you begin in a small area, and for some people that might even be gluten-free, based on what they feel works for them. If you don't mind, I would like to add that I did look it up on our website really quickly, because I know that there's interest in this specific carbohydrate diet versus Mediterranean diet, and it is at Mass General. And the principal investigator is Dr. Hamed Khalili, and it's on page 4 of our ongoing research. If there's a link to enrollment, if anyone should be interested, but it does not really specify in terms of whether or not the food will be provided, but they will be looking at symptoms as well as fecal calprotectin and C-reactive protein, and they'll also be looking at microbiome changes. So it looks like a very interesting trial.
Great, and I'm happy to promote that study on this platform. Anybody who's listening to this, learning about these diets for the first time, this is an opportunity to contribute to science and to see if it works for ulcerative colitis. If you have it, I encourage you to contact this investigator and get enrolled, because probably an exclusion criteria is going to be you starting the diet before contacting them. So maybe before jumping into it, enroll in the trial and at least contribute to research. So let's wrap this up. Meghana, Kim, thank you for making time on a Saturday to do this. Kim, if you want to just give us just a brief, how can people find what's your website, and where can they find information about you?
Well, our organization is Nutritional Therapy for IBD. Again, it's all about just helping patients and clinicians to keep up to date on the latest information for dietary information, and to help provide resources to get started, because we know that it can be difficult. So, please take a look at www.nt4, that's FOR, IBD.org. And thank you for having me.
Great. And Meghana, anything you want to plug? Any books you're writing? Any albums you've recorded? Anything like that?
Maybe next time. But again, thank you for including me with this podcast. It was a really great discussion.
All right. Great. Thanks. Yeah. Okay. All right. Thanks,
Thank you,
guys.
Samir.
Yeah, sure.